As you all know, our team is from Yashoda Hospitals, Somajiguda, and the tag for our hospital and department is multidisciplinary care, patient-centric approach, the latest cutting-edge technology, and all these are our pillars to give quality of life, as already Dr. Anant Lakshmi told, for gynec malignancies. And patient focus, quality, leadership, performance, and of course technology. Everybody is talking about technology, and medical field, especially cancer, is not lagging behind the technology. And leader in cancer care, these are for even for publication, presentations. We are one of the pioneer groups having many publications in national, international journals, and such kind of CMEs or forums we keep doing so that whatever thought process, knowledge we have or you have, you can just interact in between and share our experiences. As Dr. told that many celebrities have already cancers, in the same way they have came out, they have fought, and the same way our own cancer celebrities are also there, right from small girl of 8-9 years with the germ cell tumor of ovary to the 78 years of epithelial ovarian tumors. And fortunately, June month is a cancer survivors celebration month. So I think that would be the correct occasion to celebrate our cancer survivors and spreading the knowledge in amongst community. Coming to the gynecological advances in malignancy, we all have so many advances like our mobile phone, normal to our smartphone, even surgical, medical, radiation, robotic, organ preserving, HIPEX and sentinel nodes. So these are recent advances, most of things you know, but I'll just speak about the HIPEC and sentinel node biopsy in endometrial and gynecological cancers. So many of us, including you, keeps seeing such kind of patients in your day-to-day OPD with ovarian tumor, with ascites, with PV bleeding, cervical mass or endometrial malignancies. And these are standard procedures which we do for ovarian cancers, normally cytoreductive surgeries, omentectomies, peritonectomies, lymph node dissection, and further one step ahead is HIPEC. So what is HIPEC, when we should use, why it is now in vogue, what are the current trials or randomized control trials, and what is the evidence, and in whom, in not, and how to use it. We'll just go through this. Many times we see such patients. Yesterday only we saw one patient with distended abdomen, and she was thinking it was like accumulation of fat or gases, and she came with a bloated abdomen, ascites. In your practice also, sometimes you open the abdomen considering some benign lesion, but you'll find multiple peritoneal seedlings, the mucus kind of material or the frozen pelvis. So such kind of surgical intraoperative surprises also many times we have. So the basic pathology is how the ovarian malignancy spreads is through the omental route to because of the cycle, the gravity, respiratory movement, bowel peristalsis, and it spreads to the diaphragms, omentum, paracolic gutters, pelvis, everywhere. So cytoreductive surgery and followed by hyperthermic intraperitoneal chemotherapy. In layman's language, we call it as hot chemotherapy bath. So what are the rationale? It removes the resistant clone cells, because in cancer there are multiple clones. Some are sensitive, some are resistant. So it removes the resistant clones, improves the probability of delivering adequate chemotherapy drug, and also it removes the bulk of the disease, 70, 80, 90% of the disease. If we remove, the remaining part of the disease can be taken care with the intraoperative chemo. And the studies have shown that even short-term exposure of concentrated drug will kill the tumor cells and give the survival advantage. And the penetration of depth of intraoperatively the chemotherapy drug is around 3 to 5 millimeter depending on the drug. And what heat does, hyperthermia, what it does, it has a direct cytotoxic effect, number one. Number two, it increases the action of chemotherapy drug what we are giving, and increases penetration more than 3 to 5 millimeter into the peritoneal cavity and decreases the resistance. So in spite of having good cytoreductive surgery with the microscopic, at least macroscopic clearance, but still 70% of the patient fail into the abdomen. And the role of hyperthermia is here around 39 to 43 degrees. Because of this, what already I have explained about the rationale. And most commonly we use the cisplatin drug in the around 60 to 90 minutes depending on the protocol. And there are various evidences, randomized control trials, and now level 1, 2 evidences to support the HIPEC. Timings, when we should give intraoperatively immediately after the cytoreduction, and when the tumor volume is lowest. So what the cytoreduction does is almost 70-80% it will clear, but the microscopic or which are in the mesentery, on the bowel wall, which we cannot remove surgically, that can be taken care. And after surgery, the abdomen would be free of adhesions, so there will not be a loculated collection, so the drug will act uniformly in the abdomen, and manual uniform distribution of drug is possible intraoperative. I'll show video. And the monitoring, intraoperative monitoring of all the medical things we can monitor. Contraindication when not to do HIPEC is extra abdominal disease in lung mets or brain mets. It is not indicated. Massive retroperitoneal lymph node involvement, we cannot do that. And ureteric obstruction, involvement of bowel, mesentery, liver, and PCI more than 20. So what is PCI? It is peritoneal carcinoma cancer index. So as you can see here, abdomen is have a 9 quadrants, and depending on that, the tumor size less than 5 centimeter, up to 5, and more than 5 centimeter, there is a scoring system. Anything more than 20, 25 is difficult with amenable with the HIPEC, but less than 20, there is a good response rate. And there's one more terminology, CCR, the completeness of cytoreduction. That is 0, 1, 2, 3. That is less than 2.5 centimeter tumor, 2.5 millimeter to 2.5 centimeter, and residual tumor more than 2.5. So that always we should achieve for CCR 0 at least, or not CCR 1, so that the drug can act effectively. And he's a father of Sugar Baker professor. He's a father of all oncological cytoreductive surgeries and peritonectomies, and a lot of papers have been written, and including that sometimes we also do bowel resections and liver resections depending on the intraoperative condition. So what it is basically, it is like a heart-lung machine where we give the, after cytoreductive surgery, the hyperthermia, the saline should be, it goes into the abdomen through one inlet, comes out through the outlet, and then we give the drug. So after macroscopically removal of complete residual disease, a constant flow rate of hyperthermia is maintained. Real-time temperature, there is a monitoring of these things, and there are various protocols, American protocol, French protocol, European protocol, and depending on the drug and the patient condition, we use it. Of course, medical oncologist comes into the picture to guide the process. And after opening the abdomen, all these omentectomies, peritonectomies, pelvic, paracolic gutter resection, so that the final, the whole abdomen would be bared with the R0 resection, and you can see the intraoperative picture of retroperitoneum with IVC, aorta, ureter, everything bared off. So there are two techniques, of three techniques. One is open technique where we use the book Walter retractor, keep it open and remove everything. The other is semi-open, we keep one ioban or one aperture in between so that it reduces the toxicity of medical drug, chemotherapy drug to the OT personnel, assistants, sisters, doctors. And there's a closed technique where we, after cytoreduction, we put the wires inside, catheter inside, close the abdomen, and then do the HIPEC, the chemotherapy installation. So that is a closed technique. Everything has, both have their pros and cons depending on the situation. Gelatinous mucinous carcinoma of ovary, which has been sprayed into the abdomen, and you can see the after midline incision. All these, many times you must be also seeing in your OPD or intraoperative situation, you open the abdomen and you see such kind of jelly-like mucinous material. It could be mucinous carcinoma or serous carcinoma. It's very, flimsy kind of thing and jelly kind of thing. It was very difficult to extract everything, but with the efforts, removed everything. And can I have the laptop here so that, or hand mic? Yeah, after extraction of all those mucinous material, this is the peritonectomy. So the peritoneal layer we have to resect, because that is the main fundamental technique right from the midline to the going to the paracolic gutters, and then right side, left side, all this peritoneal layer. It's like cocoon. Everything has to be removed so that the future chances of recurrence would be less. This is the pelvic peritoneum. You can see the bladder down. Ikkada light. This. Yeah. So this is the bladder side, and this is the pelvic peritoneum. We are resecting completely that one layer. It's that flimsy adhesions we need to remove, and that plane has to be should be sought to resect that thing. That the bladder in the lower side, and then coming to the omentum. You can see the stomach here with the greater omentum. These are all right gastroepiploic vessels, and these are short gastric vessels. Everything with the harmonic or ligashua, whatever instrument have, we can use this to be, and it has to go close to the stomach. Even if smallest amount of omentum or mesentery has been residual, if leave there, it can have a recurrence. And then retroperitoneum, you can see the iliac vessels here, common iliac, internal iliac. This is the ureter, obliterated umbilical ligament. This is the sigmoid. Again, right side, left side, complete resection done. This is the retroperitoneum we can see. And then once you confirm even the lesser sac, greater sac, everything, and once you do that cytoreductive surgery, these are the inlet catheters. This is the Bookwalter retractor we use, and then lift the everything. This is a semi-open kind of technique where after Bookwalter retractor, we hitch this up, and this is the machine, actual Rand company machine. We use this patient oxaliplatin. This is the loading of the drug into the HIPEC machine, and this is the monitor where we can see real-time monitoring of the temperature, pulse, and very important is intraoperative and post-operative fluid management, very, very important. So we always, one day prior we hydrate the patient, because hyperthermia can cause dehydration. So 1 or 2 days before we start hydrating, and we take the consideration the anesthesia department for the PIC, so that everything has to be optimized. And the temperature normally we keep it around 41 to 43 degrees Celsius, and usually the time is for either 60 minutes or 90 minutes depending on what protocol we are using. And slowly after hyperthermia, the drug which will go into the abdominal cavity through these two inlets, you can see here. And this particular drug sometimes is harmful for our medical personnel, like operation theatre staff, surgeon, sisters, anesthesia. So it is a particular kind of coating is there for that. And these are two inlets which are going in, and this is the ioban which we keep so that the temperature one thing maintains and the exposure will be little less to the OT staff. And these are two outlet catheters where the drug will go in and it will come out from the outlets with two catheters again back to the machine. So this process whole takes, it may take 60 minutes to 90 minutes time. And then you can see this kind of coated coverings, and there's the person technician is available who always keep monitoring everything, whether there is any block or not, it is going into the correct. And during intraoperatively, sometimes we make a hole to that ioban and we distribute the drug into the abdomen serially. And after procedure, again we remove it, check whether everything has been okay. Sometimes there will be some hyperthermia can cause some ischemic damage to the bowel or serosal damage. So all those things we need to check. Final exploration, bleeding, hemostasis, bowel has been completely okay or not. Sometimes we do resection of the sigmoid colon or small bowel. So it has to be again checked whether the anastomosis is good or not, or if there is anything. And then we keep the, again we keep the catheters as a drainage and close it. Post-operatively, the patient we keep into the 1 or 2 days in a surgical ICU, and then depending on the recovery with the electrolyte balance and fluid balance, everything has to be taken care and shift to the patient then again into the room. So normally the most common complications are hyperthermia related issues, renal toxicity, electrolyte imbalance, sometimes basal pneumonia, atelectasis, these things. And this was the approximately 3 kilogram of that mucin with the ovarian tumor removed. And that is the next is the final histopathology. This is the omentum, peritoneum, ovarian tumor, lymph nodes, all this en bloc resection and HIPEC. So, and there are various studies, even our Indian studies are there, which quite good number of cases have been done across multiple institutes. Till now we have done around 12 HIPECs and most of them did well. One or two cases had post-operative complications, but they settled down. And this is one more rare case, germ cell tumor of the ovary. Again, we were talking about the fertility preservation. So young girl, one side germ cell tumor. So that time it was very much advanced. NSCT given with the help of our medical oncologist, Dr. Nikhil is here, he can speak about it. And then now this was 8-9 years back. Now she's young, adult, normal, menstruating and maybe probably about to get married. So coming to one more recent advances in endometrial cancer. We all know about the lymph node dissection in endometrial cancer, pelvic node dissection. But is there any way like we do in breast cancer, sentinel node biopsy to preserve the axillary complications and lymphedema? Can we do something for the cervical or endometrial cancers? So sentinel node biopsy now we are doing, and ICG is a technique where we are using indigo cyanin green. It's very common now. For breast, almost every patient who is early N0 we are using. For endometrial cancer, we have to inject that oro green, that is ICG, around 1.25 milligram per milliliter solution. And at the cervix, you can at the cervix around 3 o'clock and 9 o'clock position, 1 centimeter or 5 millimeter to 1 centimeter submucosally we have to insect. Just before the operation, open the abdomen and just see, there's this you can see here. ICG has been concentrated into the lymphatics and the surrounding nodes. So first we explore that area, we dissect the common iliac artery, common iliac vein and the ureter, lateralize it. Just see that, dissect that particular green area which will identify. Even this technique is used, many of the gynecologists they use for the ureteric identification in a bad case, endometriosis where it has been stuck and very difficult to trace the ureter. So same thing can be done here. And after removal of this particular node, we send it for intraoperative frozen section immediately. Our pathology team in 10 minutes, less than 10 minutes time, they will give us the report whether it is negative or positive. If the report is negative, I think we can omit the further dissection so that the lymphedema and all will be less. And if that load becomes positive, we can go ahead with formal complete node dissection with the formal boundaries of left to right and both sides. So that is a laparoscopic technique. And there are 3 modes in this particular, this is a striker camera with the spy feed technique. There are 3 modes, contrast mode, ICG mode and the normal color mode. So we can see the both things in a 3 different contrast areas. So this particular node has been removed and sent for biopsy. Yeah, this is the contrast mode. You can see this is again ICG mode. This you can see the uptake here, which is there in that contrast mode and ICG mode. So and then formal, once that comes positive, then this is the proper lymph node dissection. You can see all the boundaries, common iliac, external iliac, obturator now. This is the obturator now. And margins and all those things. So that is the one more, there is one more open technique, but I think because of the time I can omit it. But the same way, the camera, that is the laparoscopic probe, and the same technique we can use with the open probe. So that was all about 2 surgical advances in gynecological malignancy. One is HIPEC, for advanced ovarian cancer, and one is sentinel node biopsy for pelvic node dissection for endometrial cancer. So thank you very much. This is my cute dog.